Well, good morning, everybody. How are you? I'm not from Boston, as you can probably tell. I'm from South Carolina, and actually, two of my mentors, pharmacy mentors, taught for Charlene and still do, right? So it was quite a family. It's always fun to be with her and be with Andy, and be somewhere other than snowy Boston for sure. So it's great to be with you. I grew up in South Carolina, so a rural part of the country, and then worked in I was a pharmacist first, like my dad, like Charlene mentioned, and then also trained as a PA. I was working in a cancer center and was helping individuals who were having injuries from, the sort of unavoidable chemotherapy or radiation-related side effects, and then went to PA school because I wanted some more diagnostic skills. How we doing?
Is it acting up?
No?
Okay.
Perfect. So went back to PA school to gain those diagnostic skills, and then along the way fell in love with family medicine. I'm not anybody practicing in sort of general medicine, family medicine, primary care. I just sort of love that. And so I practiced in sort of rural communities in South Carolina, North Carolina for a bit, and then got recruited back to the Medical University of South Carolina where I had gone to school. I was a faculty there, and then sort of have moved up the East Coast. So went to Wake Forest University to chair department, really incredible health system. Then made my way to DC at the George Washington University, worked there, and also Children's National Hospital. And my family, who's from the South, was okay with that because we were still below that Mason-Dixon line. So I was technically Southern. And then I had the really incredible opportunity to join the Massachusetts General Hospital and the Mass General Brigham family. So now I'm. My parents thinks I live in Canada. I mean, I'm very close. But just have the most incredible colleagues. It's just a wonderful place to work. Some of the brightest minds I've ever sort of encountered. So I'm having a lot of fun and learning a lot. And I'm looking forward to learning from you today too. So I'm here to hopefully share some knowledge and facilitate some conversation, but your practice experiences and what you've learned and what you've found to be successful are also really important. So I hope you'll share with me and we'll have a good time today. Sound okay? All right. And the weather's not perfect yet, so it feels a little bit less bad about being stuck in a room together. So hopefully the sun will come out before. So just a few points. We're going to start off this morning talking about sort of the regulatory side of prescribing opioids. But I just want to mention a couple things. First is I've served on a couple medical boards through my career in North Carolina and also oversaw some licensure in South Carolina. And through that part, opioids and controlled substance prescribing is a big part of the regulatory experience. And so part of my hope is to share with you some of what I've learned about how you can make choices that limit your interaction with your regulatory board, which is always good. You don't want to know that they're there, but you really don't want to hear from them too much. So we'll talk about some tips to keep you off their radar. And then as Charlene mentioned, I had the good fortune in Washington to work with SAMHSA that's been doing a lot of work to try to increase prescriber education and practitioner education around pain management, the treatment and the identification of substance use disorders, and also those individuals that also suffer from mental illness. So I'll share with you some of the work we've done and what I've learned from that as well. So here's what we're going to start off with. We're going to talk a little bit about regulatory practices and opioid prescribing. Certainly been a hot topic for the last few years, will continue to be. And we'll talk a little bit about some of the latest guidelines that have just been updated. We'll kind of walk through those and try to make those work for your practice. I mean, guidelines are not cookbooks. We don't treat in that sort of cookbook fashion. We take care of individuals and their families. And so we want to make those guidelines work for us. And so we'll talk a little bit about that. And then the last thing we'll do is talk about some of the sort of tips. And I've got some cases. If we have time this morning, there's a case of an individual with some postoperative pain we can walk through. And then because sometimes we get just sort of fascinated with what happens to others, I've got some cases from my regulatory experience about practitioners and prescribers that have gotten into a little bit of trouble. So I thought it's always nice to see what happens to others so we can avoid that ourselves. So that's our game plan for this morning for the first half. What did we not talk about that you'd like to make sure we talk about? All right, well, if I missed something along the way, you let me know, okay? Excellent. So of the conditions, chronic conditions we see in the United States, What's the most common? I just want to put sort of our conversation this morning into context. What's the number one most common sort of chronic condition we see in the US? Is it cancer? Is it heart disease? Is it diabetes? Is it pain management, chronic pain? What do you think? Chronic pain. It's chronic pain. It's we do all hurt, don't we? There was a lady behind me on the plane coming who was very uncomfortable, and her husband was also quite uncomfortable by the end of that plane because she had let him know that seat was not okay, that flight was not okay. So it was a moment. But chronic pain is actually incredibly more common. So we're going to experience it. And just to sort of put it in context, you can see, diabetes. I take care of folks with diabetes all the time. I'm sure you do as well. That's about 25, 26 million Americans, whereas we're talking about 100 million Americans that are facing chronic pain. And for some of those, an opioid is going to be an important part of that regimen. Hopefully not everybody, certainly don't need it for everyone, but when it's needed, we want to be able to prescribe it appropriately. So just to put you in a little context about how common that is, 143 million opioid prescriptions prescribed in 2020. And I will say, before we sort of jump ahead, when the first opioid epidemic and the legislators sort of got involved and the media got involved, there was a lot of blame. Is it the drug companies? Is it the prescribers? Is it people that are making bad choices? Is it what are the factors? The truth is there are a lot of factors involved, but of those conditions, we as prescribers have really stepped up and made some real positive changes in the way that we manage and prescribe. We've seen significant changes over the last 5 years. I can't say it's curbed the epidemic in a big way, but we've certainly changed our practices accordingly. Who's changed the way they prescribe opioids since the media hit? Anybody prescribing more? Less? Are there conditions or types of drugs now that you just won't prescribe that maybe you did 5 or 10 years ago? I see that in my emergency medicine physician colleagues all the time. Or I see certain individuals in primary care refusing drugs like fentanyl because of the higher risk for injury. So I've seen changes in our practice. And I think the other is we're just sort of like your blood pressure, your heart rate goes up a little bit more. You become a little bit more attentive to, I'm getting ready to make a choice here that feels like it has bigger consequences maybe than it did 5 or 10 years ago. So how do I balance that risk to the patient, to myself, to our practice? So it's a big change. If you look a little bit at opioids and substance use disorder, here are opioids. Sometimes you see the term opiates, depending on whether it's a natural or a synthetic product. But opioids, really are sort of those opium or morphine-like agents that affect the brain and how we perceive pain. So morphine is sort of the prototype. You can sort of turn it into a prodrug and make codeine, or there's some synthetic ones that we know a lot about, like fentanyl, that are very, very potent. But that broad class is what we're going to talk about. And we've learned that it's really unavoidable if we treat large numbers of individuals with opioids chronically, that we'll see dependence and also addictive disorders manifest. And I think what's sort of in my career, maybe the last 15, 20 years, been a big change is really understanding addiction a lot more than we did when I was a trainee. So we understand addiction as a primary, it's a chronic, and it's a relapsing brain disease that physically changes the brain. And because of that, it'll be a lifelong issue that folks struggle with, that we can support them through, but it's also very treatable. It doesn't mean that somebody's a bad person, that they're choosing to be addicted to a drug. It's a disease process. And I use a little mental exercise sometimes to help my students and residents sort of learn about it. So who's been through a drive-through window and at one point in your life and ordered like, a combo meal number, whatever? People on the camera can't see you, so don't feel judged. Sometimes if I'm speaking in California, people are like, no, we don't do that. And I'm like, okay, all right. So let's say you're leaving work or coming home from seeing, friend or family, and you're running through the drive-through, you're having that sort of cheat day, and you order a combo meal number 1. So a drink, we're going to be healthy today, so we're not going to supersize it. So you got your high fructose corn syrup, your beverage, and you've got your burger and your fries. And so you pay, heading back home. What's the first thing that you do probably within about 90 seconds of driving away from that drive-through window? Why do you eat a Okay. All right. So what I mean, I heard like eight people immediately say French fry. Why do you eat a French fry? Why not take a big bite of the burger? Okay. What else? I mean, you weren't born genetically knowing that you needed to eat a fry first when you pulled away, right? I mean, like you might have known what to do to be able to breastfeed or to avoid injury, but you weren't born knowing that French fries is the first thing you're going to eat at a Happy Meal, right? So why is that now something that we know?
Easier one.
All right, so let's connect it to the brain, exactly what you've shared. Number one, it's easy to access, right? So, intentionally, you're thinking, I probably won't cause a motor vehicle accident if I can reach in and grab that hot little fried, fat, salty deliciousness, rather than if I'm trying to, or two, yeah, however you want to do it, or rather than unwrap sort of that. So there's the thought that I can probably do that more safely. So you're making sort of an intention. You mentioned that they're good when they're hot. Yeah, I had a cold fry. Uh, so you've had probably the experience, maybe traffic was busy, maybe something was going on where you had a cold fry, and now your brain is telling you sort of with a negative reinforcement, get it while it's hot because it gets less good. So you've got sort of that experience. What else? You can smell it. I mean, nothing better. I'm from the South, fried grease, like that's delicious, right? So you've got that olfactory sense now triggering your pleasure center and the limbic center, sort of telling you, ooh, salty, hot, fat, and it's beginning. And all of those sort of impressions physically change your brain, and you have adapted, just like we do when we grow or we have some type of other incident. And your brain now has programmed you to say, hot fry, eat it quick, we're on the road. So it's just an example, but imagine that on a larger scale. Someone's had trauma or someone's used a drug of abuse that's altered their brain chemistry, or someone struggled with depression, or fill in the blank. And the point is your brain has physically adapted and altered to drive that type of behavior. It's a minor one. You could say to yourself, I'm going to be healthy today and maybe not go through the drive-through or whatever, or maybe order a kid-sized meal instead of the big one. But it gets harder when the stakes are higher with certain drugs of abuse. Make a little sense? Okay. Nobody's bad if you did the drive-through. Just don't do it regularly. Nobody wants to live forever too. And I work in geriatrics and see some of the worst. So in terms of numbers, some of the data is a little dated, I'm sorry, but that's the government's been a little backed up with the pandemic. But in 2020, there are about 40 million Americans who had a substance use disorder. So if you put that in context, that's 1 in 7. It's sort of startling. It's a lot. A fair number of individuals that use heroin will also go on to develop opioid use disorder and addiction. And this has become a little bit more of a problem again, because as we've clamped down on prescription opioids, we now see folks sometimes more turning to illicit versions or illegal versions of those drugs. And so we've seen heroin use pop up a little bit, as well as illicit sourced opioids in the US. That's been the real concern about some of the deaths as well, which we'll talk about. So quite a lot. We saw a little problem when I was in sort of rural practice. At that point, we were starting to see more high school kids use prescription opioids. And so there's a real risk when you start to use those medications before around the age of 12. We see sort of a different course of illness. And sometimes that might just be taking a pill, not as a routine, but at the same time they might go and drink alcohol or something like that. Kids being sort of a little devious. But we found that over time, that exposure in earlier ages really does cause some long-term consequences and makes it more difficult to treat them. So a lot going on. 7.7 million Americans also have what we call co-occurring disorders. Substance use is not a mental illness. It's not considered one, although it's often treated by psychiatrists and other mental health professionals. But it can exist in the same space as a mental illness. So if you have bipolar disorder, or you have depression, or you have schizophrenia, and you concurrently have a substance use disorder, we call that mental illness a co-occurring disorder. And it's fairly common, not everybody. So the data kind of looks different on which side of the national surveys you use, but we think about 7 or 8 million Americans have co-occurring disorders, which means in addition to their substance use, they have an underlying mental illness as well. It's very hard to identify those up front. So if someone's actively abusing a substance or using a substance, it's really hard to tweak out, is there a mental illness? Because sometimes the symptoms and the signs sort of overlap. So what psychiatrists and other mental health specialists will usually try to do is attain a period of abstinence from the substance so then they can see what the individual's presentation is and what their function is without the drug. And so it's not always possible to do that, but that's how sort of that works. So I'm a primary care provider. I'm going to disclose I'm not an addiction specialist. I'm primary care. I certainly care for individuals who have substance use disorders, but I do it through the lens of a primary care. So if I identify someone who has a co-occurring mental health disorder, I'm going to be more apt to refer or get some help from them because the course of their illness can be more complicated. Bipolar disorder and substance use disorders can be tricky. There can be an increased risk of suicidality. There can be an increased use of sort of pervasive medication use. Whereas if someone has mild to moderate depression, it's very often you can manage that successfully in primary care. So I think being aware of it helps from a couple points. Treating both helps everybody do better, but also just be aware that if things aren't going as you would hope, sometimes it's helpful to have a specialist come in. There are not enough mental health specialists to take care of anybody in the US who has a substance use disorder. That's why the rest of us have to sort of step up and do our part. But I think in the case of those with concurrent disorders, it's okay to ask for some help. I even have individuals that I've cared for where I have a little discomfort, but not full level discomfort, if that's a thing. And so I may have someone see a psychiatrist or psychologist or one of my mental health nurse practitioner colleagues to say, could you help me verify that I'm thinking about the right things, that my diagnosis is okay? How does my treatment plan look? And so they may see that individual maybe even just once a year to make sure that we're on the right course. And then I'll continue to execute that plan throughout. So it's okay to work sort of collaborative like that because I'm thinking, okay, now I've helped that psychiatric practice have more space for new patients, but I know that I have them as a backup and I can sort of check in with them. So we'll co-manage as well in primary care. When I was training at the medical university in adult internal medicine, we would have a psychiatrist come into the clinic every Wednesday to co-manage people with us. It was one of the best models I've ever seen. And it's nice to have that blend. People I've also found feel more comfortable and less stigmatized sometimes if they can get some of that care or most of that care in primary care. They may feel like something's less wrong with me. So that's another option. So in terms of drug abuse, overdose, and death, opioids are absolutely the most common cause of drug-associated deaths in the US, like by far. But drug overdose is also the leading cause of accidental death among adults in the US. Really sort of kind of phenomenal numbers, but there's been an increase. The pandemic led to a pretty increase in both the use of substances and also for people that were currently using them, they used more during the pandemic. I think we probably all had those moments where we considered it, or maybe the Pinot Grigio level was a little higher as we sort of struggled through that, but it was a real challenge for individuals with substance use. Some of them also had really trouble getting access to treatment. Buprenorphine was in short supply, so there were all kind of factors going on. But about 75% of the deaths due to overdose in the US are due to opioids. So it's and if it's not an opioid by itself, it's an opioid plus other drugs. So quite a lot. And you can see kind of the three waves of opioid deaths in the US. And you can also notice over time that as we have prescribed less, we've seen changes. So if you look at the total number of opioid prescriptions in a county or in a state or in a region, you can usually sort of relate it to the death rate. So more access to drugs, more access to higher dose drugs, more likely death. It's not all that sort of complicated. But one of the things that has just really made a major change is as we've clamped down on prescription opioid prescribing, we've put prescription drug monitoring programs in place. One of the real challenges is now the influx of illegal synthetic opioids. It's a major problem for the US. We're right in Florida where we have all kind of international channels where those drugs can come in, but it happens all over the country. And you can see here how this rise in death has just been a steady upward increase. And it's the products are either very, very potent, like fentanyl, or they're adulterated with other products. And people don't realize that they're going to have this experience. And it can happen sort of very quickly. I'll just share one story with you about it. Oh, sorry, it went too far there. So I was doing some training with the North Carolina Medical Board in a beautiful town in North Carolina called Wilmington. Have y'all been to Wilmington, anybody? Beautiful. It juts out like Florida, so it gets a lot of storms, but it's a beautiful port city. They have a lot of individuals there, more than normal for the state of North Carolina, who've had workplace injuries. So they have a fair number of individuals that are on chronic treatments for workplace injuries. So we're meeting with a group of physicians and nurses and pharmacists and PAs and others there in one of the larger health systems, sort of talking to them about opioid prescribing and safety issues. We were also sort of hearing from them about some of the challenges they were facing. We were having sort of a community conversation with the prescribers. And I'll never forget it. It's a little bit of a dramatic example, but it stuck with me for a while. So we did some visits to individuals in Wilmington, and I remember going into this one home with one of the colleagues from the board, and there was a young girl. She was probably about 14, and her mom had had a pretty bad fall from a high position in a factory in Wilmington and had hurt her back pretty significantly. She'd had multiple surgeries. She'd had pretty extensive interventional pain management and a whole number of issues, but had pretty retractable pain. And so she was on a fairly complex regimen of medications, including opioids. And homebound, it was just the mother and the daughter. So a lot of pressure on this young girl. And I remember talking to the daughter, and during the week, she would say between 10 and 12 times, she would notice her mom was unresponsive, and she'd have to go start administering naloxone until she woke up again. So here is an individual, the mother, who was not actively trying to abuse. She wasn't trying to get high. She was just trying to survive a pretty intense pain syndrome, but unintentionally was overdosing or on a dose that was too high, or sometimes she would combine it with a anxiety medicine or sleep medicine. And now you got a 14-year-old having to wake her up with an antagonist drug. Can you imagine what that must be like on that family, on that young girl? All I think is I hope she goes into healthcare, because what experiences she would have. But so the situations people face can be quite significant. So our goal is, how do we reduce harm? How do we try to prevent harm? Or at least help people be prepared to manage those drugs safely. So there were a few indicators so I've told you some bad news. Let me also tell you some good news. Over the last few years, this is a 2023 report from the American Medical Association, who's been working with physicians around the country on the overdose epidemic. But you can see a few things that are a little bit encouraging. So we've seen almost a 50% decrease in opioid prescriptions that are being prescribed in the US. Hopefully that means we've selected out those individuals who really need it and maybe have thought about non-opioid alternatives for the others. We've seen a big increased use in prescription drug monitoring. Some of that is because we as prescribers want to use it. Some of it's because your state probably tells you have to, and it's a pain, but it's sort of a little more regulated. And we've seen also a pretty good increase in the prescribing of naloxone, which if you have someone on chronic opioids, it's very appropriate to make sure they have naloxone as well. So those are some good things that are happening we can, be proud of. And then we've also seen some changes here with opioid prescribing and opioid death. The one really tricky thing, though, is had we not seen such an influx of synthetic opioids in the US, I believe we would have seen a significant drop in drug-related mortality. But as we have prescribed less and seen fewer overdoses and deaths related to prescription opioids, we've seen a real spike in illicit opioids. So we have to work with the law enforcement and our immigration and our and drug enforcement agencies to see if we can get a handle on the illicit drugs. Are y'all familiar with tranq? Is that something you've heard about? This is one to sort of keep your eye on a little bit. Xylazine is a very, very potent sedative. It has this sort of a street name called Train, but it is being increasingly found mixed with illicit sources of opioids, particularly fentanyl, and that combination together is wildly fatal. Or dangerous at minimum. And so it's one to sort of be aware of. In 2021, the US government put out sort of alert, but we have really seen a spike of these in urban areas and near sort of sites of entry for illegal drug trade in the US. But that's one to be aware of. It's comparable. For example, if you would see someone who is on an opioid and who is also being prescribed a benzodiazepine, that combination together can be quite, why is that combination sort of dangerous? Yeah, so the benzodiazepine decreases respiratory status, and then that's one of the ways the opioid affects. So you see that sort of deal. It's almost like someone with chronic lung disease being on high doses of opioid, and they don't have the ability to sort of regulate. But the xylazine and the fentanyl together is quite dangerous. This is one that we've seen more and more of. Just put it on your radar. So let's talk a little bit about opioid prescribing. All right, so who's continuing to prescribe opioids, even if in a very limited fashion here? A few. And anybody just like said, no, not part of my practice anymore? So everybody has a little. And if not opioids, how about other controlled substances? Benzodiazepines, sedative hypnotics, seizure treatments. Okay. Do you feel a little differently when you prescribe those maybe than you did 5 or 6 years ago or 10 years ago? Or not really? I feel differently. I feel like I'm more vulnerable or exposed or something or at risk, which is sort of weird because it shouldn't be about me. It should be about the person I'm taking care of. But for some reason, I feel that way. And I feel like I have to be more vigilant. Maybe you do as well. So what are some steps that we can do? So a couple things is, as I mentioned before, we have those 100 million Americans with chronic pain. That's 11% of individuals. So we have lots and lots of folks that'll see us. And we know that opioids are prescribed commonly. They could be an essential part of a treatment for malignant or non-malignant chronic pain. And we know that where if we looked at 2016, when the CDC's first guidelines came out, about half of prescriptions for opioids were coming from primary care prescribers. And that number has dropped to 37% in their latest data. So the 2022 guidelines, which were updated not too long ago here, we've seen now about a little less than 40%, 37% of prescriptions for opioids coming from primary care, and a significant number also, of course, from pain management and oral surgeons and dentists and others. But the guidelines in 2016 from the CDC really focused on primary care. The latest ones have really now opened it up for all of us, whether we're in emergency care, whether we're in endocrinology, family health, women's health, wherever we're practicing. If we're in an outpatient setting or a hospital-based outpatient practice, the guidance can help us there as well. I always got nervous in the medical regulatory side when legislators got involved with prescribing. We really want to be able to self-regulate our practice. We want to be able to let our clinical expertise drive it. But the epidemic with opioids got to be such a big thing. My guess is that regardless of whatever state you've in, you've got a lot more rules to comply with. You've got a lot more checking of systems and things like that to do. All right, so a little quiz for you here. So which state has the highest rate of opioid-involved overdose deaths? So we're going to bash Florida right off the bat.
Well, you got all the entry points.
All right, well, let's give them all a fair choice. Fair enough. Who says California? We have one. Don't be shy. It's okay. Like the half race says, I'm not sure. It's no judgment. How about Florida? I know we got one Florida vote here. Any other? How about Ohio? Okay, couple. How about West Virginia? It's West Virginia. No comment there. The point of this is that the rates of opioid prescribing and the rates of opioid deaths varies wildly across the U.S. It's not a even phenomenon, but West Virginia unfortunately has the country's highest rates of opioid deaths per population. Hawaii down here is kind of on the low end. I'm not sure if I captured your state or not, but you can sort of hear where I live in Massachusetts is sort of around the middle, but quite different. And you can go to the CDC's website and even drill in on where you live and see what the density of opioid prescribing and deaths are related. Yeah, Texas is low. Texas is also spread out a lot. it often has to do certainly with prescribing patterns, but it also has to do with individuals and industries where people may be injured or hurt or more likely to get treatment for pain. But West Virginia has definitely struggled for many, many years, and they're at the top of the leaderboard here with overdose deaths. A lot of work being done in that state as well. In certain groups, we found also are more likely to experience harm from opioids than others. Don't want to generalize too much, but just a few groups. Younger folks, less than 50, particularly starting in the mid-20s, 30s, have higher rates of opioid overdose. We also see some overdose as rates differ by race and ethnicity. I've listed those for you. And men tend to have a little higher rate than women in terms of overdose death. Most deaths that involve opioids have other medications involved as well. One of the real, as I mentioned, lethal combinations is combining benzodiazepines. In some states, it's not lawful, or it'll trigger an assessment of your prescribing. But there may be a handful of exceptions I can think about where specialists are using those drugs together. But as a primary care provider, I'm not going to combine benzodiazepines and opioids. I'm going to stop it if I identify it, or I'm going to, reach out to that prescribing colleague and talk to him about it. It's definitely a high risk combo. So, we want to make sure that we can do our part. Sometimes when I'm talking to other folks in primary care or emergency care or others, there can be this sense of, I'm not a mental health specialist, I'm not an addiction specialist, this is somebody else's job. And the trouble is we just don't have enough people in the US taking care of folks with addiction and substance use. So doesn't mean we have to transform ourselves into addiction specialists, but where is the place in care that you can feel and you can make a positive impact and feel comfortable about it? Maybe it's like, hopefully you'll gain from the time together we have this week to do more screening and identification and recognize people earlier and get them to treatment for substance use. That might be one. You may want to think about incorporating treatment. So maybe you want to become a prescriber of medication-assisted therapy. You might not want to open your practice to more broadly to substance use, to individuals with substance use disorders, but maybe you want to be able to do that if you have individuals that are in your practice that develop an addiction disorder while you're caring for them, and you want to be able to keep them in your practice. You can sort of think about where you feel comfortable, but there's lots of opportunities for us either to increase screening, to increase identification, to treat, or just make sure that we're doing appropriate referral to treatment for individuals who are struggling with alcohol or drugs. But you can see a lot of need for us to lift up more access to care. It's actually, I'm a family practice sort of person, but I've spent the bulk of my career mainly on the latter end of the spectrum caring for older adults. There are lots and lots of older adults that are struggling with substance use disorders, and sometimes the way you approach them and care for them and have to treat them is very different than the way the research tells us to do in younger patients. So that's another group that often needs some help. And, we all kind of commit to do no harm. There is no perfectly safe medication. There's no benefit without some risk. And if we treat people with, you figure out, you put the drug, whether it's an opioid or diabetes medication or other, the likelihood is through our career, we're going to see people experience harm from that medication. The hope is we've done a lot more good, and the hope is we can identify them harm early, but there is no perfectly safe drug. I mean, I wish there was. Maybe water, but even that you can drink too much of. It's just part of what we have to do to be vigilant. And we have to anticipate that substance dependence and substance use can occur. And so we have to screen for it and watch it and then be able to intervene early on. Make a little sense? Y'all hanging in there with me? Are all those eggs and sausage y'all had this morning starting to put you into sleepy zone? All right, if you have to get up and wiggle around a little bit, do it. No judgment here. You got coffee back here? Yeah, excellent. I've had like 3 cups, so I'm wide open. Yeah. I have gone long periods without it, though, so I think I'm okay. It's not interfering with my quality of life. I went the whole pandemic and gave up coffee completely for a whole, 2.5 years. And then I had this most delicious cup because I was peer pressured into it at this cafe in Washington, and I was like, oh, I really miss it. I want it back again. So now I'm back on my drug of choice. But anyway, All right, so there's another sort of little framework we'll think about. So, and this has a point for a regulatory perspective, is that morphine, which we probably don't prescribe a lot of, is sort of the prototype opioid. And so all the other opioids are converted into morphine equivalent doses or morphine equivalent milligrams. And that's how the regulatory boards and the government sort of judges our practice. They convert those. So I just want to make sure you're familiar with that. So this is a conversion factor. You can actually go online to a little simple calculator and put it in and it converts it for you. You don't have to do any math. But the reason it's important is because the literature tells us a little bit about certain levels of opioids that put people in low, medium, and higher risk groups, determined on the dose of opioid. So kind of take everything else aside. We're not thinking about concurrent medications. We're not thinking if someone has like some chronic liver disease or lung disease, but we're just thinking average Americans, adults, and how much opioid are we giving them for their chronic pain disorder. And if you stay like less than 20 morphine milligram equivalents per day, the risk is very low for drug-related harm. Doesn't mean they can't still develop an addiction, because they can, but the risk of drug-related harm is pretty low. Certainly the risk of overdose death is low. At 50 morphine equivalents per day or less, we do see about a doubling of that risk, particularly in terms of unintentional overdose. And so when we go to that level of somewhere above 20, but up to 50, that's sort of a moment where we have to kind of stop and think about it. Is that dose necessary? Are they getting more benefit with that dose than they did with the lower dose? Is it worth that sort of increased risk? It's still, I'd say, in a relatively safe zone in terms of prescribing. It's certainly not considered a high dose opioid, but it's a jump that we should sort of think about and make sure that the potential increase in risk is worth it in terms of how their function is, how they're doing on a daily basis. But that's sort of the first moment. When you go above 50 and you go up, some states will put like a 90 morphine equivalent limit in their system. Some will put 100. When you go up though above 50 and you sort of approach that 90 to 100, there's a big bump up in risk, and the risk particularly of unintentional overdose. So it's sort of like this lower safe zone to a moderate to elevated risk, and then sort of a high risk. So in my own practice as a primary care person, I'm going to pretty much have everybody at 50 morphine equivalents or 40 morphine equivalents or below, because my sentiment is I know what the research says to us about the safety of that medication, and I feel like I can monitor that appropriately. And if I have to go above that with the opioid and all the other things that I'll have, going on to try to help control their pain and treat and help them be functional, if I have to go above that with the opioid, my mind says I'm not trained and I don't have the expertise to do this. I'm not a pain specialist. I don't have the experience of a residency. I don't have the experience of knowing all the other interventional treatments. And so I'm going to say I can't control their pain syndrome in an outpatient setting as a primary care provider. I'm going to get help and refer them to a specialist. So I've just sort of said for myself, if I have to go above this point, that's when I sort of pull that trigger and say, I need some help. You're really beyond the scope of me to care. Or maybe there's a physician in our practice I can talk to and say, would you take a look? Would you be willing to take them on? Or can we get them over to pain specialists? I'm in a very sort of urban area now in Boston. We have a massive health system. We have incredible physicians, lots of specialty practices. When I was working in rural family care, I didn't have so many people I could refer to. So you also may have to think a little bit about what the resources are around you. But that's sort of where I make my point. Thoughts about that? Questions about that? Make a little sense? I feel like with opioids or any controlled substances, at some point you have to kind of like have a Zen moment and reflect on what am I comfortable doing and what am I not comfortable doing? Where do I want to set those limits in the types of drugs I prescribe or the doses I prescribe or the conditions around which patients may have to comply? And I try to do that up front, so I'm very clear on what the expectations will be. I don't want to change the rules on someone I'm caring for midstream, so I think it's helpful to sort of think about that, and then practicing sort of in that principle-based way can also help you not feel like, okay, you've asked me to do something and I'm going to judge you and say, no, you're a bad person for asking me. I'm not going to do that. I'm just going to say, Part of the way that I make sure that I'm providing safe practices, I've set this limit and I'm not a specialist able to do it. So for anybody, for you, for everybody that I care for, this is sort of where my expertise ends. But I'm willing to get you some help and help you and help make an appointment with someone that can give you a more advanced level of care. I think if you can think about that, you can certainly move that up a little bit as you practice and gain more experience, but I think that principle-based approach is helpful, and it kind of takes the pain or the pressure out of the moment where you feel like you're, not giving the patient something that they want or need, or that you're feeling like you may be in a judgmental space. I've been pretty good with that. That's also how I write my pain contracts, or even I have contracts when people are on any controlled substance. And sometimes they're very short, like if it's for a sedative or something, but it says, if we're going to start this medication, here's the potential risks of it. Here's what you have to do, and here's what I'm going to do. And that's part of the agreement we have. And if that means you have to let well, if it means you're not going to request an early refill, or it means that if we order a pill count, you're going to participate with it, everybody knows right up front that this is part of the sort of plan. I think setting those ground rules is pretty helpful. Do y'all have those kinds of agreements, or have you thought about that? Or maybe you do it verbally, however you want to do it. I think it's okay. I mean, the one thing we don't want to do is think about a drug that we're going to prescribe, whatever it is, asthma medication, opioid, and just promote all the positives. I think what we have to do with individuals we're caring for is talk about the benefits and the risks and be very upfront and honest about it. Give them a chance to think about it, kind of internalize and decide whether they're willing to take on that risk for the benefit that we may see, and kind of engage in some shared decision making with them. I'm just very blunt with them. I just say, let me tell you the good about this drug. Let me tell you the safety risk. Let me tell you what I think is particularly concerning for you or not. I'm going to give you 2 or 3 choices. Here's my choice top. I think there's 3 options for what you're going on. The evidence says all 3 of these can make it better. There's some safety things we have to consider. Here's the risks. I'm going to give it to them sort of straight. And I'll say, do you have a preference, or do you feel like one of these is more appealing to you than others? And I just am really upfront with it. And I don't ever prescribe a controlled substance where I don't tell an individual that the drug can be habit forming and you can become addicted to it with regular use. And I'll say, we're going to monitor for it, we're going to screen for it, but I can't make that risk go away. So it's something that you take on if you choose this medication. You hanging in there with me? Okay. So quite a number of regulatory changes have happened, everything from insurance to law enforcement to prescription drug monitoring programs. And, what some of the things that we've seen here are greater coverage in the media, more concerns in not just the press, but in sort of the political arena. We've certainly seen lots of issues with state and federal governments. The medical boards, the nursing boards, the pharmacy boards have been under increased pressure to sort of step up their either the sanctions or their surveillance. So lots and lots of different things are happening. The CDC put together this first set of guidelines in 2016, which I mentioned were largely for primary care prescribers. It was for using opioids in the context of chronic non-malignant pain. And there's some positive things that have happened since those guidelines were put in place. And then in 2022, the latest reiteration of the guidelines came out, and that was made for a broader audience. And there was also more evidence that had been available since 2016. So when the CDC formed its first set of guidelines, all right, keep in mind these guidelines are prescribing for chronic non-malignant pain. And they looked at the research on chronic or long-term use of opioids. What do you think sort of the typical length of a long-term study with an opioid was in the research that they had to use? What do you think the clinical trials or the drug trials for long-term opioid use were? Just sort of a random question. So we're going to prescribe this medicine for years, right, for a patient, and it's approved or it's been studied based on efficacy and safety in long-term pain control. So how long is that long-term opioid trial? On average. Take a wild guess. 10 years? 5 years? I like it. What else? 2 years? Okay. Try 6 to 8 weeks. 6 to 8 weeks. maybe 12 weeks if we're really good. So one of the challenges there is that, we want to prescribe evidence-based practice, but the duration of study that we may have may not resemble real-world practice. And so I think it's very appropriate to say, based on 12 weeks of clinical study, there's going to be a lot that we don't know, and we're going to learn on an individual basis as we care for people for years with those medications. So it's also helpful to kind of know what we don't know, and to be mindful. But there are no trials of years and years and years. So just to give you a little flavor for that. I learned that early on being a faculty member in academic medical centers, that the people that would often participate with trials were the young, healthy people that would, who knows what they would do for $200 a week, but they would participate with the trials. And then I would go to clinic and I would take care of more fragile or vulnerable older adults and those people in my practice. And I was thinking, there is just no comparison between the people that they proved this hypertension study on and those. And the FDA's gotten better. They've really improved their attention to the study of drugs in target populations. They've also put in some really good rules about studying cardiovascular effects and the safety in older adults, the safety in kidney disease and renal disease. So the quality of drug studies is getting better and better. But you can see what I mean, in that when you're trying to get a drug approved and you have millions of dollars in development, there's sort of an incentive to test it in a healthier subset of the population that you're going to treat, hopefully to see better outcomes with your trials. And it's very expensive to run drug trials, and you're rarely going to see something last years for sure. So these are some of the regulatory changes we mentioned. About 20 states, as of the last time I checked a few weeks ago, had passed laws either requiring or recommended naloxone, along with certain opioid regimens. Maybe the dose was higher. It's a combination, not all. And I have to remind myself to do it because it's not something I was trained to do or I saw as I was training, but it's like a habit. And remember that depending on the dose of opioid, they might need more than one dosage of naloxone to be a remedy. So it's not just having maybe one injector or one nasal spray, but you may have to provide a supply that's appropriate for the dose that you're given. And it's just like having a defibrillator or a fire extinguisher in your home. It's a safety measure you hope you don't need, but if you need it, you want to be able to access it quickly, not have to call the pharmacy and wait for it to get filled. So it's just a safety measure. So let me give you a few tips. And Charlene, help me keep an eye. If we need to take a little stretch break and things like that, I'm mindful. We can sort of do that. But some of the things that I've learned over the years through my regulatory work are kind of what I'd call hallmarks of appropriate care, or things that keep you out of trouble or that help sort of protect your practice if you're called to question, or a regulatory board or a state investigating board says, hey, something's come up with how you've prescribed these drugs. We want to talk with you about that. We may take some charts from your practice. And so over the years of kind of sitting on the panel or the judge and the judge panel and having the prescriber and maybe an attorney or an advocate there, and over the years of being through these cases, I've sort of pulled away some things that I've thought seem to insulate people from risk in terms of prescribing. It's not rocket science, but I want to share them with you because I think if you're not already doing it, it's worth thinking about. And some of them are going to be self-evident, but I'll give you a few examples of how it plays out. So the first thing is to make sure that you document, particularly for new patients, a thorough assessment and evaluation before you prescribe a controlled substance. And I had this lived experience. I was a brand new PA working in a rural family practice in kind of near Myrtle Beach, South Carolina, if you'll know where that is. And I was so excited. I had been a pharmacist and then had gone back to PA school. My wife kind of thought I was crazy, but I did it. She probably still does. But I had gone back and I had just, this idea in my mind that I was going to take my pharmacy experience and then my primary care training and really build programs for people with chronic disease. And so that was sort of my path to do it. And I've been able to do that and have a lot of fun with it. But maybe 3 months into my brand new practice, I had my crisp white coat. It was so clean. I had just gotten my name on it and all that good stuff. I was working with some phenomenal family physicians in this little small rural family practice. And then 3 months in, one of the largest sort of pain medicine scams in the state of South Carolina gets shut down, and 9 clinicians who were prescribing massive amounts of opioid within Myrtle Beach, got arrested. One of them got, arrested on a plane to New Zealand and all over. And then we had hundreds of individuals that had been treated by this group. And just to kind of give you a flavor of how it worked, there was like a empty grocery store building within Myrtle Beach, and they would bring in hundreds of patients at the time. There was like a raised platform with the prescriber with the microphone, and they would ask some general questions. And if nobody said anything, then they would pass out prescriptions for opioids, usually alprazolam, it was a benzodiazepine, and usually a muscle relaxer like carisoprodol. So it would be very common to see an individual that had 250 or 300 OxyContin tablets, 120 alprazolam, and maybe 90 or 100 carisoprodol within a given month. Some of that crowd, I'm sure, was diverting the drug. Some of them were taking it, thinking that I'm coming in to get this care. It was the only resource they had, but it was a disaster. And then imagine here's this little brand new, eager beaver who doesn't know anything, a little bit, but not enough in primary care. And then those individuals now are out of their medicine or they're having withdrawal symptoms and they're flooding the primary practices. And you're bringing in like, here, I need my refill of 270 OxyContin 80 milligrams. You had that sort of experience or something like that, or maybe you've had a physician who retired or a colleague who retired and people are coming to your practice, or maybe a partner, left, and then you're like, oh, I don't know if I want to do that, or I'm not feeling comfortable with that regimen. It was quite a moment. And, one of the things people would say is, I've been on this for a long time. Here's my chart. Just give it to me. And I think when you have a new patient, challenge the diagnosis. It doesn't mean you have to send them for a new MRI if you have discrete results, but challenge it and go through a thoughtful reassessment. And even if you can help it, put a differential diagnosis in your documentation that you've considered other things to sort of verify that diagnosis. If not, and you're reviewing existing chart information, then just make a note in your diagnosis of what you've reviewed, reviewed images, reviewed considered this differential diagnosis, and just verify that you've done an appropriate new patient evaluation. That's one thing that gets folks into trouble when they just sort of assume that the last person that saw them got everything right, and now you're putting people on that regimen. And I'm not suggesting the triple alprazolam, carisoprodol, opioid, but that was a moment for me for practice. I learned a lot, for sure. A humbling experience. Also, which sometimes we don't always do, but it's a good practice, is if you can include within your documentation, and this is true for anything, but controlled substances in particular, if you can document the handful of differential diagnoses that you've considered, and to put that in your recommendation, whether maybe it's a chronic pain, you've considered arthritis syndromes, you considered, but actually list that you've generated a diagnosis, and then your assessment kind of helps the reviewer see that you've then considered those things and sort of what's in your mind. Because otherwise, if you just put the final result and what you're going to do, when your practice is being evaluated, the reviewer can't have any sense of what you were thinking about at that time. So particularly with a new patient evaluation, if you can generate that and document it, it helps the reviewer see that's absolutely appropriate. They were thinking about the right things. You may have still made a mistake down the road, but it helps them to see what your thought process was. So that's another one that is a really protective factor if you can show that you can show that you considered it. And we saw cases all the time where a rare, unusual diagnosis was missed. And, it happens. So they're not looking to try to get you in trouble. They're trying to verify where you practicing with usual care, where you're making appropriate medical decisions. The other is that there's the documentation of a meaningful treatment plan. So what do you think I mean with meaningful treatment plan in the case of an opioid prescription or let's don't say opioids, let's just say the treatment of someone with a chronic pain syndrome? What would meaningful treatment plan?
Increased pain.
So linking sort of the symptom with your treatment, so cause effect. Okay, there's some type of picture or blueprint. What else? What other qualities might be part of a meaningful treatment plan? And I'm going to get on my soapbox just a minute, so prepare for it. Then we'll take a little brain break. I get really irritated when we made pain the fifth vital sign. Did y'all have I don't know how you felt about that, but we really messed up as a healthcare community when we started chasing a number, or we said, you're a 10 and we want to get you to an 8. I mean, I think we really made a big mistake. A meaningful treatment plan would be thinking about if you're going to use an opioid and non-drug or non-opioid, so using a combined regimen, meaningful treatment plan would be what is meaningful in the patient's life that we're trying to improve. Daily function? Are we trying to make sleep better? Are we trying to help them work a full day? Think about, if it's an older adult who's got, debilitating pain with movement, is it a level of exercise or walking to the mailbox? What is it? And so if you can try to arrange your treatment plan such that the evaluation of it is going to be in outcomes rather than just how are they on a pain scale, it's considered meaningful. So think about function over pain level, if that's a way to sort of think about it. And meaningful also means we're trying to make meaningful improvements in their daily life, daily quality of life. I've definitely changed the way I've done that. And there's also a periodic review of the patient's concurrent sort of state towards those goals. So for example, we're on 10 milligrams of oxycodone. We're on a daily acetaminophen. Maybe we're doing some exercise therapy or some ice therapy or whatever. And we go up on the opioid dose because the patient hasn't made that increase in their function. And we come back at the higher dose of opioid or the higher dose of whatever. And we come back, and if the function has improved and they're tolerating the medicine okay, that's fine. But if we increase the dose and they're still not walking anymore, they're still not gaining any function, then we should pull that opioid back down because it hasn't made a meaningful impact. So we don't just keep raising things up. We look for some functional improvement to warrant the increased risk or the dose of the drug or the new med. Sort of makes sense? And then the last one is if your call to question or your practice or your prescribing is being investigated for whatever reason, we're going to use what we call a standard of care evaluation. A regulatory board will use the standard of care evaluation, and that's generally how your practice is assessed. So what do you think? How does your nursing board, medical board, how does it determine standard of care? So let's say there's a complaint that's gone into your licensing board. They've said, Reamer has done X. The concern is triaged by one of the investigators, and they think, okay, this is a credible complaint, not just like a mad, X somebody or whatever. We're going to move forward with an investigation. And sometimes that's just a conversation to start. And we're going to determine if Reamer is prescribing and caring for some these individuals within a standard of care. What does that mean? How does the board determine what that is? What is standard of care? I want you to know, because if it happens to you, I want you to be prepared for it, and I want you to feel confident that I got this. I'm in no trouble. A lot of people don't know until they come in and they're in front of the jury. That's one of the I always felt so empathetic. I mean, there were a few bad actors, but the majority of them were good people that were trying to do the right thing that just made some mistakes or started to go down a path that wasn't usual care, standard of care. Okay, so standard of care as it's determined by, like in medical malpractice or by an investigatory board, is generally meaning the minimum level of competent care that somebody in your discipline would meet to meet the quality of care that the state defines as lawful, which is a horrible legal definition. So I'm going to tell you what it means in real terms, but that's what the law says. A standard of care is intended to support some level of consistency and quality between PAs or pharmacists like me or physicians or nurse practitioners or others like you. So to say there's a certain level or minimum level of competency and quality care that everybody should get. You're going to have some that are way over the top that are phenomenal, but there's a minimum level of treatment that you should expect from a licensed healthcare provider. And sometimes the state will elaborate on what that looks like, but that's what it is. And it's based on your peer group, internist or physician or pharmacist or advanced practice registered nurse. And the question usually comes down for a board is what would a similarly qualified and reasonable healthcare professional, fill in the blank, physician, APRN, PA, do under the same circumstances. They're not looking for what the chair of the department at Johns Hopkins or Mass General Hospital would do. They're looking for what would your qualified, reasonable peers do in the same situation. And the way that we execute a standard of care investigation is just usually through review by peers. So let's say you live here in the Fort Myers area, Florida, Bonita Springs, really pretty, and you're being investigated. They may identify two, sometimes three, and let's say you're a general internist. They'll find two other general internists, in general medicine that are in good standing with the board, and they'll provide, let's say, those 10 charts of whatever the patients they've pulled, and they'll say, we want you to review these cases, and we want you to provide input on what would you do under the same circumstances. And it's usually through that peer review that occurs. Now, you might make different choices. You may prescribe a different medication, but they're looking through to say, is this practice, is this testing, or this history taking, is this prescribing, monitoring, whatever, consistent with usual practice? And so standard of care is determined in the moment by those peers for an individual circumstance. It's not a guideline. It didn't say, did they do what the CDC said? It's looking for, so standard of care always changes, and it occurs in that moment by that peer review. So you just want to make sure that you're not doing worse than your peers. You don't have to be better, you just have not to be worse. That's the goal, to stay out of the trouble with your regulatory board. So what are some things that you can do to help support making sure you're doing at least what a similarly qualified and reasonable healthcare professional would do in the same situation? What are some things that you can do to help support your meeting that standard of care level if you're ever called to task on it? Simple things. Don't practice in isolation. That's a fantastic thing. Being here together. Yeah, what do you think about this? Talk to it. Some of us are in solo practice, but most of us aren't. Have conversations. If it's not in your practice, maybe it's at a meeting at the hospital or association, a group like this. Maybe it's getting together with some colleagues, periodically for lunch and talking about it, but don't practice in isolation. That's one thing that I saw over and over, particularly in North Carolina, where we had a lot of folks where it was like the only physician or the only nurse practitioner in the town, and they didn't, they were so busy or they didn't communicate with others, and they started to say, well, I've been doing this, so it must be okay, and they didn't get to sort of benchmark what they were doing against the rest of their profession. It could also be going to, CME events. I think it's really important that you do some things also. Here we're a national group, but it's also good to do things in your community or your state or your region where you can be around peers that are in the same practice area. That's a great thing to do. And these are complicated situations, and there's like 78 new journal articles every day that are published that we should be following. So it's hard to keep up. All right, what else? I've always worked in multi-practices where we have multiple practitioners. And one of the things like some of the physicians or advanced practice nurses and I would do together is because, like we may travel or we may do things, we would kind of like they do when you're going to have a baby and you're in a OBGYN practice, they let you see the other people in the practice. We would periodically have one of our folks see somebody else, like for a follow-up visit or a check-in, one, so that there was some rapport, but also just so we got to peer review each other. That's one thing that you could do as well. Another is you can, like one thing I did after the opioid guidelines came out is I randomly pull 10 or 11 charts from my practice. We have electronic health records, pretty easy to do. And I went through the 12 recommendations from the CDC with those 10 or 11 charts I had and looked to see like how often did I do, 9 or 10 or 8 and when did I not? And by doing that, I thought, okay, it looks like Reamer forgets to do this more often than that. And so then I sort of changed my practice. So you can also do some sort of self-looks at how that may be. But it's not practicing in isolation. It's staying up to date enough with your peers that you feel like you're in the same space. Make a little sense? Again, not rocket science, but I'm telling you, it's not, you just want to make a few choices that'll keep you out of trouble.
one of the things that state boards will typically not expect you to do is they won't require that you have a pain contract. They're not going to expect you to do urine drug screens every time. They may ask you, or the state may ask you to look at a prescription drug monitoring program, either when it's a new prescription or a refill. Some states require it every time you prescribe a controlled substance. But, the state is not going to say, okay, they don't do urine drug screens when they prescribe opioids or benzodiazepines. They're a bad prescriber. They're going to be reprimanded. They don't do that. They just want you to have a plan in place that's appropriate. So if you want to use pill counts or drug screens or pain contracts, do it. If you don't. But here's the trick. If you're called to the jury and you have urine drug screen and pill counts and you get an abnormal result and you don't do something about it, it's very hard to defend yourself. So don't have 3 failed drug screens and then you just said to the patient, you need to do better or something. Like you have to sort of follow up with the rules. It's like, I don't want to say good parenting, but it sort of is. You have to sort of meet at the moment and have some, discrete events that occur if someone in that agreement that you made with them doesn't live up to their part of the expectation. And one of the reasons I don't really use a lot of urine drug screens is I just find them too complex to add to my practice. So I may say in my pain contract, if there are concerns, we may initiate a drug screen, but I rarely use them as sort of routine. Now I do use pill counts and I do use sort of other, and a pill count is a kind of easy thing to do. I learned this from practicing in rural family medicine when I got duped by an older patient one time who was diverting some opioid. And a pill count is just making sure people, and so, have what they say they have or about what they say they have in their bottle left. And you don't have to come to the practice for that. Because I've had people say, like, it's too inconvenient for me to come to the practice. And like, there's a CVS or a Walgreens on every corner. It's fine. Go to a pharmacy, go wherever you want. So we sort of bake that in. That's a helpful thing. And if either you can do it sort of randomly or you have a concern about diversion or misuse of a drug, then you can issue a pill count. But just do what you're going to say you do. And don't make your monitoring plan so complicated that you don't feel like you can consistently implement it. Because when you're called to task about it, you're going to have to defend that practice. Well, you put a pain contract in, but you didn't do anything that you said you're going to do in it. Or these 3 things and it just sets you up. Looks like you're not. It can present a picture of negligent practice or below standard of care practice. They often also look at your response in the face of evidence of possible abuse or addiction. Do you continue to prescribe? Do you document an encounter? Do you make a referral to substance use? What is it that you do? And how do you address it? Because it's okay that you have a patient who, through chronic opioid therapy, develops dependence or develops an opioid use disorder. I mean, it's going to be unavoidable, as I said. It's going to happen. But when that happens, what do you do about it? How do you, and in some cases, maybe someone develops an opioid use disorder and they continue to be treated with opioids because they need it as a part of their drug regimen, but it's kind of be managed in a different way. You may have an addictionologist help you with it, or you may have a different type of product, but it's what do you do in the face of possible substance use, abuse, or diversion? And the other thing, and then we'll take a little brain break, stretch break, bathroom break, is remember that complaints come from lots of different places. So my very evidence-based advice is be kind to others. You don't want to really irritate that person at the front desk or whoever because they will, it can make your life a little discomfort when they maybe have some insights or they have a perception or they can say things to harm you. And it doesn't happen a lot, but it happened enough over the last 15 years or so that I've served on boards just to say, respect the other people in the team. You might not always agree with them, but show them some kindness, and you'll actually see some of the personalities that get more complaints to the board or those that maybe don't always offer that kindness to people that they're working with or in their practice. Karma? Well, I'm going to say kind. Yeah, be kind. I always think about this blockbuster, be kind, rewind things. But just remember that complaints can come from a lot of different places. And there are a few people that will see a complaint as a way to try to push back or retaliate against you. The good thing about it is boards are good at seeing through most of those, but it's just a little bit of a help.